Good evening, everybody. I'm Dr. Dennis Goodman. I'd like to welcome you to our Heart Health Lecture Series, which is part of the Center for the Prevention of Cardiovascular Disease at NYU Langone. We are delighted tonight to have a fantastic speaker, and as you all know, a very important, timely topic, osteoporosis and heart health, why bone strength matters at every age, and I will introduce our speaker shortly. As I said, I'm in the Department of Preventive Medicine, a clinical professor, and I'm also Director of Integrative Medicine at NYU Grossman School of Medicine. I want to, just before I go to the Q&A, to thank Anya, who always helps me put these programs together. Anya Coach does a fantastic job, and I'm really, really grateful. And now a couple of logistics. The Q&A button, you all know. I know most of you are veterans, and if you want to ask a question during the talk, you can just write the question, and I'll be fielding them during the talk, and I'll take as many of the questions as possible. And we've also already received many questions that have come in on email, and we're going to take as many of those as possible as well. Next slide. So please stay connected with us. I know many of you are connected. That's how we get in touch with you. We'd like to have your email. Our website is nyulangone.org/hearthealthlectures. That's our email. We're on Instagram and Twitter. Next slide. So we have a video library, which is on YouTube, which we're really proud of because we've been recording these lectures for many years. We've been going since 2015, and we've got over 60 lectures now. And you can actually find them on YouTube. The website address is nyulangone.org/hearthealthlectures, or if you take a picture of this QR code, it'll take you directly to the YouTube channel. Next, just another point that I'm so proud of, we've had close to 100,000 hits on these lectures. So it really, the message really is getting out there. So tonight you can listen to our great speaker again if you want to. And if you know someone who's missed this, you can make sure that they get to hear the recording on our YouTube channel. Next slide. So we are open for registration on our next lecture, which is going to be on Tuesday, December 9th. We're going to talk about heart failure prevention, made simple, what you need to know. So that's Tuesday, 9th of December. Please save the date. Next slide. So now to our speaker. The topic is osteoporosis and heart health, why bone strength matters at every age. And it's such an important topic. I'm sure our speaker, Dr. Leung, will tell you. I think there are 12 or 13 million people with osteoporosis and many, many more with osteopenia. She's going to explain what that's all about. But let me introduce our speaker tonight. This is Dr. Nicole Leung. She's a clinical assistant professor in the Division of Rheumatology and Department of Medicine at NYU Grossman School of Medicine. We are delighted to have her. She's a board-certified rheumatologist at the NYU Langone Osteoporosis and Bone Health program. She attended medical school at Duke University and internal medicine and rheumatology training at NYU. She's one of our alma mater. She has specialized training in bone density as a certified clinical densitometrist, as well as musculoskeletal ultrasound. She works closely with a multidisciplinary team of primary care physicians, gynecologists, orthopedic surgeons, physical therapists, and radiologists to provide patients with the most comprehensive and well-coordinated care. Everybody needs to know about osteoporosis, just like you need to know about cardiovascular disease. They are linked. We're going to hear about it tonight. Nicole, Dr. Leung, thank you so much for joining us. We are looking forward to your presentation.
Thank you so much for inviting me today. It's so exciting to be here because this topic is just so near and dear to my heart. And I think it's so important for not just, postmenopausal women, but patients of all ages and all genders. So today we'll talk a little bit about, what osteoporosis is, and then we'll delve into the natural history, and then later on evaluation and treatment. Let me share my slides. Can you see my slides?
Yes.
Okay, great. So again, I'll talk about the definition of osteoporosis, so to make sure everyone is on the same page. Then we'll talk about challenges in an awareness or misconceptions about osteoporosis. Then we'll delve into the nitty-gritty about the natural history of bone over time. We'll talk about fracture risk at different ages, and then the primary and secondary causes of osteoporosis. We'll talk a little bit more about premenopausal osteoporosis, as well as osteoporosis in men, some things that previously weren't as well highlighted. And then we'll talk about certain medications that could be related to osteoporosis or lower bone density. Then finally, but most importantly, we'll talk about how your doctor might evaluate you and diagnose and treat you for the osteoporosis. We'll talk about the medication options, when to use which, and then the role of supplements, exercise, and other lifestyle changes. So osteoporosis is a disease that is characterized by low bone mass and an increased risk for fragility fracture. A fragility fracture is a fracture that occurs at standing height. And here are micrographs of bone. On the left is normal bone, and on the right is osteoporotic bone. And as you can see clearly here, that when trabecular mineral is depleted, the individual bony plates and their connecting branches or rods are lost. And this leads to less resilient and weaker bone, and bone that's more likely to fail at normally tolerated mechanical loads. So osteoporosis affects 12 million Americans, and another 35 million have osteopenia. And 1 in 3 women and 1 in 5 men over the age of 50 will experience a fragility fracture. There are actually 2 million new cases of osteoporotic fracture per year. And surprisingly, this exceeds the number of new cases of MIs, breast cancer, and prostate cancer combined. And we expect this incidence to increase to 3 million by 2040. So this is a big issue. And despite how common fractures are, there are still challenges in awareness of the root cause of fractures. A survey that was performed in the US amongst more than 1,000 postmenopausal women found that 35% of the respondents were unaware that the osteoporosis was the cause of their fracture, and majority thought it was just them being clumsy. And 55% of respondents were unaware that one osteoporotic fracture actually might increase your risk for additional fractures and additional imminent fractures. And 18% felt that they could not do much to reduce the risk of fracture at their age, which is not true. And we'll talk a little bit about the treatments later on at the end. So, spine fractures are one of the most common fractures. And so after the first spine fracture, patients' risk for subsequent fractures increased. So after first spine fracture, one's risk for a subsequent fracture is increased by 5-fold and 2 to 3-fold at other sites as well. And then if a patient has had 2 or more spine fractures, then their risk increases even further, 12-fold. And if you continue to have very low bone density, in addition to prior history of 2 fractures, then you are almost guaranteed to have another spine fracture. And so why do we care if we have a spine fracture? Other than experiencing the acute pain from the spine fracture or the height loss, it's important to remember that multiple spine fractures can lead to restrictive lung disease, for example, if it's multiple thoracic fractures. And lumbar fractures, the lower part of the spine, can also alter abdominal anatomy, leading to worsening constipation or early satiety and weight loss, and then eventually loss of muscle mass. The most common locations for spine fractures due to osteoporosis are in the T7, T8 or thoracic T7, T8, and then as well as where your thoracic spine transitions into the lumbar spine, and in those 2 locations. So aside from spine fractures, there are many other types of fractures that are associated with bone fragility. So let's take a look at the most frequent osteoporotic fractures by age. In patients younger than 70, as you can see here, wrist fractures, as shown in the cerulean blue bars, are the most frequent fractures. So oftentimes patients will come in their 50s to 60s, and their first, I call it the gateway fracture, will be a wrist or distal radius fracture. And then we get a bone density, and the patient realizes they actually have osteoporosis. In patients who are 70 years and older, as you can see in the royal blue bars here, that's when hip fractures start to become more common. And looking at all patients, you can see that hip fractures account for the most ED visits in both men and women. And then the wrist fracture in cerulean blue comes next, and then the spine comes closely behind. And then the humerus, pelvis, and femur fractures. So fractures of fingers, toes, and the skull are actually not not considered true osteoporotic fractures, since they are typically traumatic and generally unrelated to low bone density. So how do patients get to this point of osteoporosis? So let's rewind a bit. So you have a basic understanding of the natural history of your bone over time from when you're a child to an adult, and then we'll talk about the pathology of it as well. So around 50% of your peak bone mass is obtained during your adolescence. And then there is continued but slow building until your early 30s, where your peak bone mass is achieved. Then during that time, there's a plateau in your bone density. Around your mid-late 30s or early 40s, you start to have bone density loss. And starting in the fourth decade, women and men start to lose muscle mass, about 3 to 5% per decade. And after 50, that might even increase a little bit more. And during this time with the muscle mass, there's an increased risk for falls. Then menopause occurs around early 50s, 50 to 51 or so. And due to loss of estrogen, the bone resorption exceeds bone formation. And the combination of both, bone loss as well as muscle loss, leading an increased risk for falls, results in increased risk for fractures. And then as we age, there's accelerated loss. So first, during menopause, the hormonal changes affect the spine first, so the trabecular bone first. And then later on, that's when the cortical bone starts to become affected. And then by age 80, it's expected that about 30 to 35% of peak bone mass is lost. And during menopause is when, women lose the most bone density at an accelerated rate. So about a 10 to 12% decrease in spine bone density, so about 1 T-score unit. And we'll talk more about that later, about what a T-score means. And that occurs during menopause. So what that means is that about half of women are losing bone even faster than that. So up to 20% loss during that time period of menopause. So I want to talk about peak bone mass just because this pertains to, it's important to know because people don't think about osteoporosis and low bone density, when they're young. But it's really important to understand that, your peak bone mass and density is achieved when you are, a young adult. And that starts even when you are 3 to 5 years old. So one study here showed that physical activity stimulates bone growth in diameter, and bone mineral content relies on both physical activity and calcium intake in prepubertal young children, 3 to 5 years old. And so, as you can see on the graph here, this graph represents young children who were given either placebo or supplemental calcium. And the gray bars represent those that participated in higher physical activity, so gross motor activity, versus kids that only participated in fine motor activity. And the calcium intake was about 1,100 milligrams per day. So what they found was that as you can see, kids who had both calcium intake and physical activity, gross motor activity, had a higher bone mineral content. Oops. And this graph on the right shows that, and sometimes, and we'll talk a little bit more about men versus women bone density there, but you can see that men have 8 to 10% higher peak bone density than women. And just this slight difference in peak bone density achieved in their youth makes a huge difference in, when fractures occur and when osteoporosis begins. So now let's talk a little bit about the pathology. I wanted to show you this electron micrograph because it allows patients to visualize what's going on inside their bones and why these medications do what they do and can be helpful in patients with high risk for fractures. So in a normal bone environment, there exists an equilibrium between bone formation by osteoblasts and bone resorption by osteoclasts. And this helps maintain your bone mass over time. In osteoporosis, however, and again, during those first 10 years of menopause, this equilibrium is disrupted, resulting in bone resorption, surpassing bone formation. So the pendulum swings over to bone loss. So you can see on the electron micrograph on the right here an actively resorbing osteoclast. So what happens is that the cell attaches to the bone, and then you can see SC here are the sealing zones. And then so it attaches to the bone, and then these ruffled borders or RB, protons are secreted, and that demineralizes and it resorbs the bone. It first demineralizes the minerals there, and then later the collagen, the structure is also affected and broken down by proteolytic enzymes. So that's a depiction of what happens. So the primary cause of bone resorption are hormonal changes during menopause and later on hormonal changes for men later on in life. I wanted to touch base quickly about secondary causes of osteoporosis that are important to know, because the most important aspect of treatment is to figure out what your underlying cause is. So when you come to my clinic, our first session is especially long because I ask you a lot of questions about your clinical history, just to figure out if there's anything else outside of your age and hormonal changes that could be resulting in you having lower bone density. So for patients who have premenopausal osteoporosis, common causes of osteoporosis would be genetic or developmental bone disorders. And oftentimes, endocrinologists who see patients with osteoporosis will then care for patients with hypophosphatasia and osteogenesis imperfecta. Other common causes of premenopausal osteoporosis are patients who have anorexia, and especially those who have amenorrhea from anorexia. And then also patients who don't have anorexia, but have exercise-related amenorrhea. And that's now called relative energy deficiency in sports, or REDS. And then I wanted to highlight the pregnancy or lactation-related osteoporosis a little bit more, because few people are aware of the secondary osteoporosis. And then, of course, inflammatory autoimmune conditions can also increase your risk for premenopausal osteoporosis. So, for example, patients with lupus and rheumatoid arthritis can also have increased risk for low bone density at a younger age. And then medication-related osteoporosis is also really important to talk about, and we'll talk, and I'll share with you some medications that can do that. So pregnancy and lactation-related osteoporosis, the clinical manifestations are patients, who are usually lactating. They experience multiple spine fractures. And, it's interesting because most people, after pregnancy, their bone density actually improves. But in certain cases, it doesn't. And we think that it's because, during that period of time, there might not be enough calcium intake. So 80% of fetal skeleton calcium content is achieved during the third trimester for pregnancy, and the highest requirement for maternal calcium is actually during breastfeeding. And when there's extended lactation, where there's more than 6 months of breastfeeding and 70% of energy intake from the child is from breastfeeding, then there can be a dip in bone mineral density. Because I want you to think about, your bone density, your bone as a reservoir for calcium. And so when there is lactation, then the maternal skeleton is demineralized to meet the demands of reproduction. And so, as you can see in the graph on the right here, it shows a percent difference of lumbar spine bone density from baseline. And then on the X bar, it's the time from birth. And so you can see that about 6 months after breastfeeding, there's a dip in lumbar spine bone density as well as femoral neck bone density. And then thereafter, most people recover that. However, I think in certain cases when women don't get enough calcium during this time, then that's when we think that they are at risk for multiple spine fractures. So now let's talk about osteoporosis in men. The key takeaway of this slide is that in men, we should suspect secondary causes of osteoporosis. So up to half of cases of male osteoporosis are from secondary causes, either hypogonadism, so hormonal changes, or if they are taking certain adjuvant chemotherapies for cancer, prostate cancer, and other drug-induced losses. The peak bone, as we talked about before, men are somewhat protected because their peak bone density is a lot higher than women. So that results, their bone formation during adolescence is slightly different from women. And so they have a larger cross-sectional diameter in the femoral neck and the vertebra, resulting in greater bone strength. However, males do experience higher morbidity and mortality after hip fractures compared to females. So it is still really important for men who are at risk for osteoporosis to identify that early on before that hip fracture. And now we realize that the hormonal changes for men include estradiol. So multiple studies have shown that reduced serum estradiol is actually an independent risk factor for fractures in men. And so the key is estradiol and free testosterone, and low free estradiol and testosterone is what leads to an increased risk for bone loss and fractures in men. So here's a list of some of the medications that can contribute to osteoporosis. And some medications are better studied than others. So for sure, steroids can lead to decreased bone mineral density for both men and women. So we think that usually steroids that are higher than 5 to 7.5 milligrams of prednisone for more than 3 months really can reduce bone mineral density. If you are on steroids for less than 3 months, there might not be as much of an effect. And then there's other medications like proton pump inhibitors that are sort of more mixed. And then SSRIs, often used for depression, can also lead to lower bone density. There's also other treatments like androgen deprivation therapy and tamoxifen for breast cancer treatment that can lead to low bone density. So now we're going to delve into talk about how your doctor will diagnose you with osteopenia or an osteoporosis, what a T-score means, what a Z-score means, and then we'll talk about treatment of osteoporosis and osteopenia. So the World Health Organization defines the diagnosis of osteoporosis way back in 1994 using a DEXA or dual energy X-ray. So this is the exam that you get where you lie on a table and then they check to see, what your bone density is. Bone density is a measure of how much minerals, such as calcium, that you have in your bones. And they look at the spine and the hips, and sometimes the forearm. And it uses very minimal radiation, much less than a chest X-ray. So for postmenopausal women and men aged 50s and 50 and older, we use a T-score for diagnostic classification. So a T-score of -1 and more positive is normal bone density, and a T-score that's between -1 and -2.5 means that you have low bone density or osteopenia. And when you have a score that's -2.5 or more negative, that means you have osteoporosis. And a Z-score, sometimes you'll see physicians using a Z-score, and that's usually used for premenopausal women or men younger than 50. And we use that when we think that you have more of a secondary cause of osteoporosis. So when will your PCP usually send you to screen for osteoporosis or osteopenia? So currently, the ISCD organization recommends workup for low bone density in women who are 65 or older and men 70 and older, regardless of if you have risk factors or not. But if you are 50 and older and you've had a history of a fragility fracture, or if you have any risk factors that we talked about before, then you should also get a DEXA. Other reasons for getting a bone density is if you have had significant height loss, for example, then you should get a vertebral fracture assessment to make sure you haven't had any subclinical spine fractures, because actually, a majority of patients, about 75% of patients, don't realize that they actually have had spine fractures before, and only 25% of patients realize they had spine fractures before. So if you've had height loss, usually more than 1.5 inches between, your peak height to around 70 or before, then you should get a vertebral fracture assessment. That can also often be done via bone density or through X-ray. So for patients who've already had a sentinel fragility fracture, either in the hip or spine, then no matter what your bone mineral density is, then you likely benefit from a bone strengthening medication. If you've had a fracture of the proximal humerus in the arm, or your pelvis, or a distal forearm, and you have osteopenia, meaning a T-score between -1 and -2.5, then it is recommended that you also are treated, because benefit outweighs the risks. For patients who have never had a fracture before, then you should get treated or bone strengthening treatment if your bone density is really low. So for example, if your T-score is less than or equal to -2.5 in the femoral neck, total hip or lumbar spine, or if you have osteopenia, low bone mass, but your FRAX score, and we'll talk about that in the next slide, what that means. If your FRAX score is high, meaning that your risk for a hip fracture in the next 10 years is greater than 3%, or if your risk for a major osteoporotic fracture is greater than 20%, then you should also be started on a bone strengthening treatment to help minimize that risk and improve your bone quality. And then third, if you are on chronic steroids, more than 7.5 milligrams for more than 3 months, or less than that, but you have a high risk for fracture, then you would probably benefit from a bone strengthening treatment as well. And I think a lot of this is a case-by-case basis. So, for when you come to my clinic, we go through your whole history and your whole picture to see when we start you on medication or not. We look at, your clinical risks and then your very closely. So let's talk about FRAX now. So what is FRAX for and how is it utilized? FRAX stands for Fracture Risk Assessment Tool, and it determines your risk for a major osteoporotic fracture or hip fracture in the next 10 years. It was mainly studied in patients who are 50 years and older. So you can see they take into account your parental history of hip fractures. And it only counts if your parents had a hip fracture younger than 80. And it also takes into account, alcohol use and steroids. So now I wanted to also touch base about trabecular bone score. This is a more advanced imaging analysis that evaluates the quality, the microarchitecture of your lumbar spine. And you can get this assessment with your bone density at the same time. So what it is that it looks at the textural analysis of the bone. And so people who can have a bone with same bone density, but very different quality and microarchitecture. And let me go to the next slide and show you the difference. So patients can have the same bone mineral density report, but very different TBS. So on the top shows patients with well-structured trabecular bone, healthy bone. And then below you can see altered trabecular bone. So the more red you have, that means the worse your bone microarchitecture is. And the higher the number, the TBS score, the better. So 1.35 and above is usually considered normal. As you can see on the top picture, you can see that, it's well-structured bone. And the bottom picture shows higher anisotropy, which means that the pattern of bone differs according to the direction of measurement. And that suggests that you have poor quality of microarchitecture in the spine. So, if you haven't gotten a trabecular bone score yet, I would recommend for you to ask your doctor for one at your next bone density. And that can tell you a little bit more about your risk for a fracture. So now let's talk about risk stratification. And I wanted to highlight this today because identifying people, who are at high risk for fracture is key because that can really help patients avoid fracture. And it's important to identify those who are at high imminent risk. So who's at high imminent risk? Those who've had recent fractures within the last 2 years. So then they're at high risk for a recurrent fracture in the next 2 years. And then patients who have had a history of multiple fractures are at higher risk for another fracture in the next 2 to 3 years. Those who are at high risk are those who have fractures despite osteoporosis medications. Patients, again, who are on steroids for more than 3 months are also at high risk. Those who have very low bone mineral density. So that's considered patients who have a T-score of less than -3 in the spine or less than -2.7 for the total hip are considered low bone density. And then, or if your FRAX score is very high. So if you have a greater than 30% risk for a major osteoporotic fracture in the next 10 years, or greater than 4.5% of risk in hip fracture in the next 10 years, then that's also considered very high risk for fracture. All right, so once your doctor risk stratifies you, then they'll talk to you a little bit about your treatment. So generally, patients who are low risk, they'll talk about lifestyle changes and supplements, and then they'll also talk to you about bisphosphonate therapy and estrogen modulators and estrogen, which then they'll send you to your gynecologist, and you can talk about the risks and benefits of hormone therapy, and then if you are at a certain age range, then raloxifene and low bone density and osteopenia, for example, then sometimes raloxifene is a good choice for patients. And then for patients who are more moderate risk, then Reclass and Prolia is used. Reclass is the IV version of the oral bisphosphonates. Fosamax is the most common medication that most people have heard of, and that's usually a weekly medication. And there's other versions of Fosamax like Risedronate or Actonel that can be monthly as well, or Beniva, which is monthly as well. Bisphosphonates have been in use since like the 1990s, and it can reduce your risk for a spine fracture by 50%, shown in the FIT trial, and can increase your bone density anywhere between 4 to 6%. And then the Horizon trial, which was for Reclass, also showed that Reclass can decrease patients' risk for spine fractures by about 70%. And then for patients who are at high risk or imminent risk for fracture, then a lot of times patients will be prescribed Prolia or anabolics first. In the more recent years, it's recommended to prescribe anabolics first, which are Evenity or Forteo and Tymlos, just because studies have shown that the transit going from a bone building medication like an anabolic medication to Prolia is better than going from Prolia to an anabolic. That can get a little bit tricky. Prolia is a very well studied medication. It's one of the few bone strengthening medications that's been studied for an extended period of time amongst thousands of patients for 10 years. During those 10 years in the Freedom trial and the Freedom Extended trial and then the post hoc analysis, it showed that Prolia continued to increase bone mineral density and decrease risk for fractures during those 10 years. Yeah. So now let's talk a little bit about supplements and lifestyle changes. I know many of you are interested in this, and this is very important because, medication alone is insufficient. It's not one or the other. It's really lifestyle and supplement as well as medications for a lot of patients that really can make a difference in decreasing and minimizing your risk for fractures. So I recommend for patients to make sure that they have adequate calcium intake. And so what does that mean? So studies have shown that in patients who don't get enough calcium. So most people need at least, 800 or so milligrams of calcium, preferably through their food, in order to not have any abnormalities in their urine or their blood. And ideally for patients who have low bone density, and depending on your age, you should be getting about 1,000 to 1,200 milligrams of calcium per day. And it's preferred through your diet because it's best absorbed. Calcium is best absorbed slowly throughout the day. If you can't get enough through your diet, then that's when supplements will be important. Vitamin D is important because that is key to helping you absorb the calcium through your food, through your gut. And so the range of vitamin D level recommendation is anywhere between 30 to 50. Some people prefer 40 to 70. But the key is to have consistent vitamin D within that good range. And so for patients who are borderline at 30, I do recommend vitamin D intake. Most people in the Northeast do need vitamin D, both men and women. So about 800 to 1,000 international units per day. And then exercise. Exercise is also very important. So we know that patients who are people who are sedentary and don't get at least 30 to 45 minutes, 3 to 4 times a week of weight-bearing exercise, even walking, can lose bone density or have more age-related loss of bone density compared to patients who are more active and do weight-bearing exercise. Studies have shown that patients who do higher intensity or higher impact exercise can have slightly improved, more statistically significant improvement in their bone density compared to patients who do lower impact exercise. The two main trials that looked at this are the MedX-Op randomized control trial in 2021 and the LIFT-MOR trial, the lifting interventional trial for patients. And that was in men and women, so 2017 for women and then 2020 later on for men. And it showed a significant difference in the spine and in the femoral neck. And the difference between the two trials were really the MedX incorporated medications, so anti-resorptives, and it showed that anti-resorptives slightly also increase the bone mineral density. The issue with these two trials really is that we don't know about the reduction in fracture risk. So we hope that in the future, these trials can be extended to show improvement in fracture risk as well. So I want to touch base about other lifestyle changes. So smoking cessation is really important. So if you're smoking, make sure you limit your smoking or cut it off. And then alcohol use, try to limit it to less than 2 to 3 drinks a day, 2 for women and 3 for men, and ideally even less than 1 drink a day. And then making sure that you're not having recurrent falls. If you're having more than 2 to 3 falls a year, make sure you let your doctor know. And then it's important to go to see a physical therapist so you can address any postural or gait issues early on. And then it's important to maintain an ideal body weight. So oftentimes people who are underweight, with, for example, a BMI less than 20 or 19, that can increase your risk for lower bone density or osteoporosis. And we used to think that, patients who are heavier, are protected against fractures. And in a way it is. However, patients who are obese with very high BMIs, that's actually associated with increased risk for fractures because unfortunately, the greater BMD, bone mineral density, is insufficient to compensate for the increase in fall impact. And so patients who have normal bone density but high obesity actually can still have fractures. So thank you, everyone. I know we covered a lot. I wanted to get, the basic information in for everyone to have to get a good understanding of what osteoporosis is and what the process is that your doctor goes through for evaluating you and treating you for osteoporosis. I currently see patients at the NYU Osteoporosis Center, and these are some of the rheumatologists in our division. And then the endocrinologists at NYU also see osteoporosis patients. So thank you for your attention, and thanks so much for inviting me. I'm happy to answer any questions.
Thank you so much, Dr. Leung. That was fantastic. Comprehensive. You covered a lot of ground. Before we end today, I'm going to give people that are listening your contact information. There's a lot of questions, and so we'll try to go through as many as possible. I'll take one or two that have been sent in, and then we can take some of them that have come in while you've been talking. How can you prevent further bone loss if you already have osteoporosis and also had a vertebral fracture?
Yeah. So I think the key part of this is to figure out what the cause of your osteoporosis is. Before I start my patients on anything, I always try to figure out what's causing your low bone density. So some patients have low bone density and have had a fracture because of that, because of secondary causes, like we talked about earlier, medications or hormonal issues, or like whether they have a very high parathyroid hormone, hyperparathyroidism, or because of their kidney disease, for example. So we first figure out what the cause is, and then we decide what the next step is. So, if we think that there's no secondary cause and this is truly age related, or perhaps because, perhaps some people never reached a peak bone density. And so they've had low bone density for a long time now. And then, the fracture is just showing up now because they're falling and have had low muscle mass. Then that's when really medications can help you increase your bone density. So for example, Evenity can, one of the bone building medications, and arguably the most effective bone building medication, anabolic therapy, can increase patients' bone density by 15, sometimes 20% in the spine, like a whole standard deviation for patients who have really low bone density. Yeah.
And as you said, if patients are able to exercise with weight-bearing type exercises, that also helps to improve the bone density.
Yes, definitely. So interestingly, and I'm glad you brought that up because interestingly, some patients who are on medications but don't make those lifestyle changes, so continue to not to exercise or continue to not incorporate calcium or vitamin D or continue to have low vitamin D on their blood tests, those patients actually don't exhibit as much of oftentimes don't exhibit as much of an improvement in their bone density, even with medication. So it goes hand in hand. And in patients who have osteopenia or borderline osteoporosis, where medication might not be needed to have that, to minimize your risk. So medication is really mainly needed if we think that you are at high risk for fracture or high imminent risk for fracture, and we want to quickly reduce your risk. Yeah.
Okay, great. Could you clarify fragility fracture? I think it's important that the audience understand that really means that you're having a fracture with a fall from standing. There's no major trauma. You may, or even, a lower level, height level than standing. And how do you analyze a fragility fracture, and what's your definition? Because you mentioned it a few times.
Yes. Thank you for bringing that up. And, You said it exactly right. So a fragility fracture is a fracture that occurs from falling on standing height. So if you fall from more than 2 to 3 steps of stairs, that's not necessarily considered a fragility fracture. So you should talk to your doctor about that. If you fall off a ladder, for some people are doing renovations or climbing up to their window, that oftentimes might not be a fragility fracture. And you take it with, you have to decide that with your doctor. It's decided on an individualized basis. And then the most common osteoporotic fractures are those in the spine, the femur, the pelvis, and the humerus or the arm, and the distal radius or the forearm fractures. So these are usually considered osteoporotic or fragility fractures. And there's other categories of fractures. Sometimes younger females or athletes can have insufficiency fractures and fatigue fractures. So there's other
Definition.
types of fractures that
Uh,
are not really related with
yeah,
osteoporosis. And then toes
I
and
got a
skull
question
fractures
about
are
that
usually not
actually.
osteoporotic.
I think the important thing is that people understand that if you don't have osteoporosis, you're unlikely to fracture something with
Yeah.
these falls from a standing height or a lower level. It's if you fracture something from those levels, it's very likely that you do have osteoporosis. It needs to be screened and checked for. That's why I think you talk is so important that people should go and get a DEXA scan when they have a fragility fracture. It's an absolute indication, correct?
Yes, exactly. Yeah, a lot of people think, it's because I'm clumsy, that's why I fractured. No, you should get your bone checked because even if you're clumsy and you fall, oftentimes, from standing level, you don't fracture. So thank you for summarizing that.
No, sure. So we got a question. Why is a hip fracture, why does it have such poor prognosis? Just to validate what this person is saying, I actually wrote a book about, which I'll mention, vitamin K2, and part of the research, I found out that 25 to 30% of people, elderly people, die within the first year after a hip fracture. And it just shows you there's so much comorbidity and mortality. It's from the hip, it's not necessarily from the hip fracture itself, it's comorbidity that comes from that. And maybe you could just mention one or two of the problems that occur.
Yeah. Yeah, so hip fractures are the fractures that we really want to avoid, the most important fractures, because as you said, morbidity and mortality. So oftentimes after a hip fracture, patients are, bedbound or more sedentary during that recovery period. And during that time, patients lose a lot of muscle mass or become more stiff. And so it's hard for people to recover that muscle mass thereafter. And so it's really key to avoid that initial hip fracture in the first place.
Exactly. Not only that, they're in the hospital, sometimes for a prolonged period of time. There's an increased risk of pneumonia, cardiovascular complications like DVT, and even heart
Yes.
attacks, and are more common, and
Yes.
sometimes even related to the fact that they may need, surgery and they're fragile. So they need
Yes.
anesthetics. I mean, they do need surgery, and so the anesthetics play a role in terms of increasing risk. So there are many, it's a good question and many reasons to do everything you can. Um, I've got a family member who's 92, and she was walking in Central Park West, and it's not very, it's not very smooth there if you've ever walked on those cobbly stones there. And she's very strong and fit. She does gym all the time, and she fell right onto her face. She put her hands out, and she's an incredibly strong. She works really hard, doesn't have osteoporosis, and didn't break anything, but she's black and blue on her face. So it's so important and so easy to fall. So, one of the things that actually Gary Player, who's a famous South African golfer, says, you've got to keep your legs strong as well. So muscle strength is so important as you get older because it helps to prevent these falls.
Yes. 100% agree with that. Yes.
Next question, Anya. Implants and pulling out teeth are critical to an aging, let me just move this, population, however, not allowed after osteoporosis treatments. How are these competing health needs addressed?
Yeah, I'm so glad you bring that up. And I talk about this with patients when I go through the risks and benefits of the medications. So, I only recommend medications when you're at risk for a true fragility fracture, much outweighs your risk for a possibility of something called osteonecrosis of the jaw. And so I want to clarify that, implants and extractions are not allowed after starting osteoporosis treatment, and also depends on which osteoporosis treatment. The guidelines actually recommend to go ahead with the extraction or implant if it's needed, because the risk is so low with these medications. So the risk of osteonecrosis of the jaw on oral bisphosphonates is as low as on the scale of, 1 out of 10 to 100,000 patients or so. But then, and the risk really is increased in patients who have a history of, let's say, like anemia or steroid use or certain chemotherapies that can affect your blood vessels, or patients who are smokers or have had history of poor wound healing. Those things can, likely increase your risk for osteonecrosis of the jaw. And then extraction and implants can also slightly increase that risk for the osteonecrosis of the jaw. But, because your risk for a real fracture is much higher, then, there's no need to, avoid, avoid the implant extraction if you do need one. And then, so certain medications don't have this risk. So example, Evenity, which is the anabolic therapy. Sorry, not Evenity, sorry, Forteo and Tymlos. Evenity has a small risk because it's still an anti-resorptive medication. And then, yeah, so that's the main one, Forteo and Tymlos,
Do you
and
think,
raloxifene.
do you think you need to notify the dental surgeon or the dentist if you're on these medications?
Yes, so oftentimes dentists will ask you because they, study it during dental school too, because it's important. They oftentimes treat it, the osteonecrosis of the jaw. But yes, let your dentist know. And oftentimes they'll give you, antibacterial mouth rinses before and after, or oral antibiotics if they sometimes feel like your risk for that is high enough.
Okay. You mentioned the toe, and it's interesting. We got someone who wrote in and said, can you explain how the demineralization of the toe would factor into the osteoporosis? This person, I'm not sure how old they are, but they don't have osteoporosis. Their DEXA scans have been normal, but they seem to have a problem with demineralization of the toe.
Yeah. So, because the morbidity and mortality of toe fractures are not as significant, I have to say that foot fractures are less well studied. So we don't have many large studies on demineralized osteoporosis treatment for just that area. And oftentimes it's like the fractures in the toe or the feet are a combination of prior trauma or osteoarthritis or degenerative changes, and not necessarily true osteoporosis. Yeah.
Right. Interesting. So I forgot to mention this person has celiac. We do know celiac disease is associated with increased risk, isn't it?
Yes, it is. Yeah, patients with celiac can sometimes have poor absorption of nutrients, and that can lead to lower bone density or quality. Yeah.
Yeah. Next question, Anya. Any recommendations for calcium supplements that are not huge? In other words, it's a big problem. Some of these calcium tablets, sulfate or carbonate, they're very bulky and it's hard to swallow. So,
Yeah.
and the gummy bears are full of sugar. So, what do you
Yeah.
tell people? And do you try to tell them to break them in half? And you've got to just take more of them, and break and then smaller size tablets.
Yeah, I'm curious to hear from you what you recommend patients, but I usually recommend patients to consider almond milk, or an extra cup of milk. So sometimes certain brands of almond milk can actually have a lot of calcium in it, like 450 sometimes milligrams of calcium. And one supplement, one pill of calcium is usually 500 or so. So if you can drink cup of almond milk, over the course of an hour or 2 hours, then you can, skip that calcium supplement, that large pill.
Right. And and
Yeah.
some of them are scored, and I tell them to break them in half and try to take it like that.
That's a good idea too.
But the bottom line with these calcium stuff, if you can get enough calcium, from your diet, as you pointed out, you may not need the high doses of calcium supplementation.
Yeah. Yeah,
Is-
exactly. Yeah.
Some people are very nervous about, the milk products but drink almond milk, if you don't want to have the lactose.
Yes.
There is good amount of calcium in milk, and almond milks and
Yeah. And I usually give patients a list of foods and how much calcium it has, and later on I can give you a link to a website that is a calcium calculator with a lot of foods listed, and you can just click through it and see how much calcium you get on an average daily basis to see if you get enough through your diet, which is the best way to get it.
Exactly. Uh, Does vitamin D, calcium, and other nutrients one might take typically for bone health have any adverse impact on arterial plaque? And I've got another question about somebody who's got some calcification in the aorta. So now they're worried about taking calcium supplementation. And what do you say about that?
Yeah. So it's funny because these studies for calcium and um, have been sort of somewhat going back and forth since since the 1990s. But the takeaway I think is that you want to have adequate calcium, but not too much calcium supplement. So if you get enough calcium through your diet, you don't need another 1,200 milligrams of calcium. So if you come to my office, we'll check your urine to make sure, also check that. But if you're taking too much calcium supplement when you don't need, then then that's not necessary. So in terms of the studies, what is somewhat controversial is we don't know if the increased calcifications in patients who are taking calcium supplements are due to more like stabilization of the plaque leading to more
Right.
calcification, because it's not clear that the size, I think, of the plaque actually grows over time with an increase in calcium. And so I think more research needs to be done on to confirm that. But in the case where that is true, where increase in calcium supplement can increase arterial plaques, that's why we do recommend for patients to get their calcium through diet.
100%. So that's the point. And I think that we know that through diet, it doesn't seem to influence calcification.
Yeah.
Uh, but with the supplements, it can, and we're not clear when it does and when it doesn't. You
Mhm.
know, so I try when someone has a lot of calcification in the vessels to say, well, let's try to get your calcium supplementation from the diet
That's right.
where it's safer. Um, so I've got a question here. Senior citizens above 70, what should they observe in their body and what exercises should they do and what should they eat? And just before I forget, I want to throw at you, somebody wrote a question about yoga. Is there any risk with the yoga poses? Do you
Yeah.
feel people, elderly patients doing it? It's great. But if you start yoga and you're really stretching, especially those, bend forwards, is there a risk of a fragility fracture if you're osteoporotic and you don't know it?
So there is with certain exercises. So we have patients who have osteoporosis, and this is really in patients who have osteoporosis and very uh moderate to severe osteoporosis in the spine, where rapid twisting, especially with weights, can increase your risk for a spine fracture. So, for example, things to be careful about are, for example, gardening. A lot of patients like to garden. And then when they're carrying things and twisting, that can result in a fracture. We've had patients who've also had spine come in for a spine fracture after just sitting in a couch that's too soft and then all of a sudden getting up too quickly and fracturing. So yeah, there are many things that can cause fractures in the spine, unfortunately, in patients who have very low bone density. Um, and so, for senior citizens above 70, and what exercises they should do, it depends on, their exercise history. But, I don't want patients to avoid weight-bearing exercise, or strengthening exercise. I think that's key. The key is gradual increase in intensity. You don't want to go from no exercise to, benching. The key is just gradual increase in intensity. Yeah.
And I always tell the patients, don't surprise your body. Start the exercise, start slowly. Um, so we're getting close to the end here. I just want to quickly throw this out. Someone's asking about collagen supplements. Do you recommend them? One of the questions here is about, should women take them postmenopausally? What are the side effects? Is there any risk to them? I will just say there is a risk. The dose is about between 2.5 and say 25 milligrams a day. A lot of men are taking it. It's protein. And so you have a risk if you've got, kidney disease or gout. You need to speak to your doctor and make sure that you tell them if you take it. But what about osteoporosis and collagen? Just a quick word on that.
Yeah. So I think there's not enough researched yet for osteoporosis and collagen, but we do know that collagen is a key component of your bone. So just because we don't have enough large studies, just because studies are hard to do for collagen, might not mean that it's not important. So what I tell patients is that, there might be more benefit than harm if, you're not having any issues, side effects with the supplements. If, there's might not be harm in taking it, or even better, getting collagen through your food. Yeah, so.
Right. Just before we end off, because I've had these questions about magnesium, vitamin K, boron. I'm an integrative physician. I've written actually a book about magnesium called Magnificent Magnesium, another one about vitamin K2. I do believe they're very important for bone health.
Yes.
Boron as well. I don't think you have to take a supplement. You can eat prunes, but these supplements can be helpful. Vitamin D we've spoken about. It's very easy to check a level, but the others are important to know about, and maybe it's something that we'll do one day in one of the seminars. But I'm a big fan in certain situations of magnesium. Not certain situations if you're not getting enough green leafy vegetables. And we should just point out that in Japan, people who ate a lot of K2 through natto in the eastern part of Japan had less osteoporotic fractures and less osteoporosis. So there's really something to natto and vitamin K2. We know that vitamin K2 actually activates osteocalcin and matrix GLA protein, and that binds calcium to bone. So it actually helps with reducing osteoporosis, but it doesn't prevent it. And it doesn't, it doesn't reverse it. That's very important to know. So thank you so much. Here's your information for everybody. This is where Dr. Leung practices. They're the phone numbers. I'll give you a few seconds to write it down. She's got two offices at NYU Langone and another one in Gramercy. And then next slide. If you'd like to see one of our preventative cardiologists, you can make an appointment. That's the number, 212-263-4300. Thank you so much, Dr. Leung. That was fantastic. You did an amazing job. You're our expert on osteoporosis, and I'm sure you're going to get a lot of people wanting to come and see you, because in the end, it's got to be personalized. We can't sit here on a lecture and tell you exactly what you should be taking. Be evaluated properly by an expert like yourself, and then you'll be getting the best treatment. So Anya, thank you again, and we'll look forward to seeing you all on December the 9th.
Thank you, Dr. Goodman. Thank you.